It's often that fear and the lack of knowledge around why we do it. The analogy which my supervisor back in the day told me is when you're looking at an ultrasound, picture yourself in a dark room and you're holding a flashlight and you're just shining that flashlight on the ceiling. That's what an ultrasound it is. So you're only going to see the parts of the ceiling that are lit up. Whereas when you do a mammogram, it's like turning the whole lights on. You're going to see the whole ceiling because it's the whole picture. Right? So that's why it's important, because you might feel a lump over here. If we only do an ultrasound in that one spot, we're missing the cancer that's on the inside of your breast.
Today's episode is one I've been genuinely looking forward to because we're stepping into a conversation that sits right at the intersection of medical expertise, women's health advocacy, and the kind of soulful healing that only movement and breath can offer. I'm joined today by Sarah Ham, a Mammography Supervisor and Medical Radiography Technologist and yoga teacher who has spent more than 2 decades working directly in women's breast health. She's someone who has seen thousands of women walk into a screening room carrying fear, uncertainty, and sometimes a lifetime of stories about their bodies. And she has made it her mission to help those women feel informed, supported, and seen. But what makes Sarah's perspective so powerful is that her career has unfolded alongside her own very real experiences of loss, grief, reinvention, and healing. After losing both her sister and her mother to lymphoma, she turned toward yoga as a way to steady herself, regulate her nervous system, and rebuild from the inside out. That decision eventually grew into a second career, teaching yoga, opening her own home studio, and weaving movement, breath, and community into her everyday life. In our conversation today, we will explore the world of breast imaging in a way that feels accessible and empowering. We talk about who should be getting mammograms, the different modalities available, and the myths and fears that keep so many women like myself from getting screened. We also look at midlife through the lens of prevention, breast density, self-advocacy, and how to navigate a medical system that sometimes feels intimidating or rushed. And then we move into the heart of it all, how breath, yoga, and fitness can help us process grief, regulate our stress, and reconnect to a body we may have ignored or mistrusted for years. Sarah's story is a beautiful example of how women can hold 2 careers, one deeply clinical. So Sarah's story is a beautiful example of how a woman can hold 2 careers, one deeply clinical and one deeply healing, and let both of them shape her in meaningful ways. So settle in. This is a conversation about breast health, midlife shifts, emotional resilience, and the quiet power of coming home to your body again. And I think you're going to walk away feeling both informed and inspired. Please join me in welcoming Sarah Ham to the Menopause Disruptor podcast. Welcome back, listeners. Today, I'm joined all the way from my home studio. Sarah, welcome to the Menopause Disruptor podcast.
Thank you so much for having me.
This is a very important topic we're going to discuss, one that I have been avoiding: mammograms and screening for my breast health. I actually thought, Sarah, about maybe we should just do this in the hospital. Wouldn't that be fun? But
to take too much time.
I think the most important thing to address right now is, why is it so important for women's health to get screened?
Because it's one of the few things that we can do for ourselves that doesn't necessarily require a doctor's referral if you're coming for a regular screening mammogram. So definitely women can, if they don't have any new breast concerns, if they're over the age of 40, if they don't have breast implants, they never had breast cancer, all those women can just phone and book their own screening mammogram through the BC Cancer Screening Program. They don't need a doctor's referral. So that's one thing, is that you can take that into your own hands.
Nice.
There are, and I mean, we might get into that later, but there's definitely a lot of mixed messages when it comes to when we should start screening. And Some doctors say, oh, no, it's okay. You can start at age 50. And that is the current recommendation. However, it is available starting at age 40. So I'm a big advocate of telling women to go ahead and start getting their screening mammograms as early age 40, because over my career, I've seen multiple dozens, probably hundreds, thousands. I've been doing this a very long time, of women diagnosed with breast cancer in their 40s. I think it's really important to take advantage of that when it's available to us. And then, mammograms are the gold standard for breast imaging.
Okay.
So basically they will detect a fair amount, most breast cancers. And we can get into some of the limitations of mammography and the other supplemental modalities, such as ultrasound, MRI, those kind of things. But as far as your basic screen for mammogram or for breast, we're looking at mammograms.
Wow. Personal story. I was recently married, moved to Goose Bay, Labrador, the military base there. So this would have been 1996. So I was only 27. And lo and behold, I still remember sitting on the front deck of our military housing. And I don't know why I was doing a breast check then, but I don't know, maybe I just come back for a run or something. And I was just whisking away sweat and I felt something very uncomfortable. And I panicked because I remember health class in grade 6, and they gave us an example of what a cancer could feel like. We had this little ball, and there was the little bead. You're like, that could be cancer. And that's all I kept thinking. But it hurt like a son of a bitch to touch it. Fast forward, after I finally got my screening, a mammogram, when I was sent away to Newfoundland to get that done. And it turned out it was just cystic.
Yeah.
A cyst in the breast. But scared me to death. And I did keep up with mammograms thereafter, but then I stopped. And I think many listeners can relate. I stopped because I started getting down that rabbit hole of it's bad for us and there's better imaging modalities, I guess you will, or other options out there. But I didn't keep up with the technology, the research, the science that tells us this is a good thing. But just how has mammograms advanced in, I don't know, like even the last 30 years, 20 years?
Yeah. I became an X-ray technologist in 1999. So I've spent more than half of my life now taking X-rays. And right away, as soon as I graduated from BCIT, I was trained to do mammograms in the Lower Mainland. And so I've been doing mammograms since 1999. And of course, when I first started, it was all film technologies. Cassettes, we go in the dark room, develop our images, bring them out. Very early technology. Old school. So since then, of course, we came into the digital era, and actually that happened while I was working at St. Joseph's here in Comox, and mammography was actually the first modality in medical imaging to go digital, as far as even X-ray, CT, all those things. Yeah. So we were the first one to go completely digital, which was really cool back then. So we got rid of those big processing machines. We were able to see our images almost immediately. They also have algorithms so that they, rather than having to repeat an image because, say, one part of the breast is really, really dense, and so the X-ray won't penetrate through that as well as the fatty tissue. We might have to take an extra one or do 2 for one breast or that kind of thing. Now there's algorithms built into the machine that will automatically fix that a little bit and manipulate the image so that we can see everything clearly. So those are some early things, and that's going back at least probably 15 years now or more that we've been digital. No, longer than that, probably. I would say it was probably around 2005 maybe that we went. It's been quite a while. Yeah.
Okay.
And then there's been more advances as far as, well, just to mention, we actually just did get a brand new machine here in the Comox Valley as well last month. And we're thinking we were supposed to have this conversation last month for Breast Cancer Awareness Month, but it didn't quite work out for either of our schedules. So we're a month late. But But yeah, so with the newer machines, we have the capability to do tomo, so tomography, which is like a cross-sectional slice image, similar in a way to like CT scan, which is computed tomography, or CAT scan. So it's taking the layers of imaging to create a 3D image. So we'll be having that capability. Of course, we're doing more biopsies under mammography guidance, whereas previously they would be only under ultrasound or perhaps even just in a doctor's office only by feel for palpable lumps that you can feel, not necessarily things that you could just see on a mammogram and not feel. And then one of the latest differences, new implementations, is for breast surgery. So when women have to come for their breast surgery, they've detected a small breast cancer and going in to have like a lumpectomy. So they're previously they would have to come to our department the day of their surgery and get a wire placed into their breast. We call it like a roadmap for the surgeon. So they'd have to come early in the morning. We'd, under either ultrasound or mammogram, we'd place a fine wire, localization it's called, into the breast, taking a lot of pictures and placing this wire. And then basically the patient goes to surgical daycare. They have this wire sticking out of their breast that we have to take down and they have to be mindful of until their surgery. Now there's new technologies. It's called molly seed that we're using here. And it's basically like a magnetic seed that we implant in the breast. And we can, the good thing about it is we can implant it up to 30 days prior to the patient's surgery. So they can come in anytime before their surgery date and have that implanted. And then the day of their surgery, they can just come in and go straight to surgery. They don't have to have the whole wire and all of that done on the day of. So it gives a bit more flexibility with booking, especially with patient in remote areas too. So some places don't do like the localizations. They might do the breast surgery, but not the localization. So yeah, just lots of different new things.
So this seed in itself, what exactly does that do that's implanted?
So basically it's which is not to be confused with a breast marker or a breast clip. So whenever a patient has a breast biopsy done under ultrasound or a mammogram, which is called a stereotactic biopsy, we usually leave a little marker behind. And that's just to show where we took the biopsy from. We leave a little we call it the breadcrumb trail behind, and that shows up on their future imaging. So if it comes back benign, we just have a little marker showing up on their future mammograms to see where we took the biopsy from. It was proven benign, we're all good. So patients that doesn't come back benign, it is maybe cancer or something that they want to take a closer look at and actually remove surgically, then the patient now needs to go for that localization. So this is, instead of putting the wire, and they're putting an additional marker, but it's this time called a molly seed. It's still very small. Like the clip that we use during biopsy is like half the size of grain of rice. I'd say a molly seed is about the size of a grain of rice. So very, very small. Yeah. So that goes in. And then when the patient goes to the operating room, they actually have, it's almost basically like a metal detector where they place it on top of the patient breast. I haven't seen it in action in the operating room, but we did get a little like rundown on it when we first implemented this. So basically, it's just a machine where the surgeon will hold it over the breast and it will target and like give you a green light when you're right over that area of where the seed is. And then they proceed with their surgery that way.
And so going back to the biopsy then in itself, when like either they've done, say, the ultrasound, the tomography that you...
So ultrasound biopsy or the mammogram biopsy, which is called a stereotactic biopsy.
So any one of those, if they detect something that could be worthy of the biopsy, then.
I would say this is a perfect time to break for a word from our sponsors. Guess what? You, my listeners, are my sponsors. That's right. I would love it if you could support the show. Helping me will help bring these amazing episodes to you each and every week, just packed full of information to help you on your menopause journey. And to support the show, all you have to do is go into the show notes and click just above where you read Meet Your Host. In green is Support the Show. You click on the button and it'll bring you to a page where you have the option to donate monthly, 3, 5, 8, 10. You can be a loyal supporter for as long as you want with recurring fee as little as $3 a month and opt out at any time. Each investment goes directly back into producing episodes with even better content, improved audio quality, and will go a long way in bringing great guests onto the show.
Yeah, so whenever the patient has a biopsy done under ultrasound or mammo, we leave a little marker in. And then sometimes the patient doesn't need surgery, but if they do, then the patient has to, again, have this localization, a different marker put in. Some surgeons, and for some certain cases, we still do have to use the wire. But for the most part now, we're using this Molly seed as well.
Okay.
Yeah. Sorry, there's lots to, I know.
It sounds daunting.
Yeah.
It truly does,
Yeah.
because we're talking about breast tissue
Yeah.
and just the idea of sliding them underneath that tray and going squish, squish, squish. And those are some of the persistent fears that are attached to the idea of having to get a mammogram.
Yeah.
So how do you work with, or can the medical system, but in particular you, meet the patient, the client coming in where they're at, to calm the fears and the anxiety associated with the mammogram, be it just having to go through the procedure and the fears that might be in their head that, oh my goodness, what if they find something? Because it is one of the most fearful things, and you can speak to the statistics after about breast cancer. It's such a fearful, daunting, and admittedly, probably one of my big fears too.
Well, first off, I forgot to say right at the beginning because I didn't really get a chance, but I'm not a doctor. I'm an X-ray technologist, and I'm no way representing any health authority or anything like that here today as well. Just want to set that straight. This is all about my experience as a mammogram tech. I've been the mammo supervisor for 12 years. So I've worked only mammography, not X-ray anymore, for the last 12 years. So this is where all of my experience is coming from. But as far as getting into patient fears, yes, it can be very heavy work. In general, a lot of the modalities in the imaging department are dealing with cancer, right? Like CT, MRI, ultrasound, even X-ray. We're all there to diagnose cancer. Mostly just for mammography, it is just cancer. That's all we're looking for. We're not looking for a broken breast, right? Like we are an X-ray, like a broken bone.
Right.
So it's all about cancer, really.
Yeah.
So of course, there's going to be increased fear, and when it comes to something as personal as a woman's breast, then it even exaggerates that fear a little bit more. The thought of perhaps losing a breast or being disfigured or anything like that. And then a lot of it comes from family history. You've had these patients that come in and they've lost a mom or a sister or a daughter to breast cancer. So, it's the fear is real. And so I think it's just a matter of meeting people in a compassionate way and listening to them and just telling them as much information as you can, being transparent. Obviously, we're not allowed to say a lot during a patient's mammogram as far as the results go, but just educating them on the steps as to what will be happening for their exam with their results, for their future mammograms. All of that is very important, especially when it comes back to women that are getting called back for additional imaging. So women that come in just for a regular screening mammogram, I would say that in general, the anxiety is a little less than it is for women that are coming in for a diagnostic mammogram where they have a new lump, or they've had previous breast cancer, or they've been called back for more images from a screening mammogram. So those all now go into the diagnostic category. And those women obviously can be a little more anxious. I'm not to say we certainly get a lot of women that are anxious just coming in for regular screening mammograms, maybe because they have family history or maybe just because they're uncomfortable. But in general, personally, I wouldn't go into a screening mammogram worried that I have breast cancer. You're doing something proactive for your health, right? You're not there because you have a concern. You're just doing all the check marks, right? So I try to say that to my women if they are feeling uncomfortable. Like, look, you're doing all the right things. You're here for your health. You don't have any concerns. You're getting regular screened. You're doing all the right stuff. So, that itself is reassuring. And then, yeah, for the women that have legitimate concerns or fears with getting the test done, there are a lot of women that are just fearful of the actual exposure, the radiation. There's a lot of unfortunate, false information out there regarding, I'm not going to get into all of that, but there is certainly a lot of things that circulate that are, from my perspective, my understanding, just not true. So it leads into that bit of the fear mongering thing. Yeah, we're not causing breast cancer by taking mammograms. We're not spreading breast cancer. Putting compression on the breast during a normal mammogram isn't going to cause harm to your breast. We work with the patient to be sure that we check in with them when we're applying the compression. If a patient ever wants us to stop, we'll stop. It's a two-way street. So we have that conversation. We try to make our patients feel as comfortable as possible. I've learned over my career that I think working in public, you're always going to get a variety of people that walk through the door, right? There's some people that are just never happy to be there, and that goes in any situation. But when you add that fear to it, then it can even be stronger. And not everybody is pleasant. I can just say that. but I find that killing them with kindness is the best medicine, because just turning around, if someone comes in and is fearful, or not fearful, but just maybe not super polite or anything, just being extra polite, or that just seems to help the situation. And it does help to calm them down a bit as well.
In particular, if they're coming back on a second visit.
Yeah. And I want to talk a little bit about that, because some women, when you have your regular screening mammogram done, we only do the standard 4 pictures. So we do 2 from the top, 1 on each side, and then 2 sideways views. And with this BC Cancer Screening Program, we're only allowed to do those four views. So if we see any extra thing that we want to take a closer look at, we don't do that during that test. The patient is required to come back for additional imaging. However, we do check for image quality. So if the patient's breathing, there's motion, we've clipped off an area, that kind of thing, we do repeat the images. Because we get a lot of patients come in, when they get called back, they say, "What? They didn't do it right the first time," or it's like, no, we checked that the images were fine. It's the odd time maybe we didn't notice something, and we get called back for there's deodorant on or something like that. But that doesn't really happen very often. The number one reason why patients get called back is because there's been a change in their mammogram and they need more images. So radiologists always compare with previous images if there are some available. And anytime there's a change from your current mammogram to your previous, we will usually call you back. But we look back. So say you've had 10 mammograms, and they always look at the one that you had 2 years ago, and then the one you had 4 years ago and 6 years ago, and they'll compare back quite a way. So that's why it's so important for women to have regular mammograms and not just come and have one. It's not a one and done situation.
We haven't seen you since 1996.
It's not a one and done. Mammograms are all about comparison. So getting that first baseline and then coming regularly. So every 2 years, if you don't have family history or personal history of chest radiation, or you haven't been tested for the gene, genetic testing. Some people have that done. They're BRCA1 or BRCA2 positive, so high risk. So anyone that's not high risk is just every 2 years, age 40 and up. Everyone, see, I'm going off on a tangent now. I feel like I'm jumping around, but
that's what we do. We disrupt conversations.
And then people with a first degree family history, so mother, sister, daughter, or father, brother, son, with breast cancer, are yearly. And and then every 2 years for everybody else. But so having your mammogram coming every 2 years or every 1 year, whatever, we compare. So
to know. Very good.
So I do also tell patients that when it's their first mammogram, there's a higher chance they might get called back because we have nothing to compare with. And that is true, because we have to make sure that their tissue, that's normal for them.
Okay.
So anyways, when patients get called back, we usually go through some additional images, what are called spot compression views or magnification views. So those are the typical views that we do. We would also be doing like tomography. This new machine we got, we'll be doing that. We're not quite there yet, but we will be. So those are kind of things that we'll be doing in replacement of these spot images. It's still a mammogram. It's still going to put you in compression, unfortunately.
Still have to hold your breath.
So usually patients come back and they have these spot compression views. So we're focusing in on one area of the breast tissue that the radiologist circled for us on an image, and we're spreading that tissue out much better in that one spot.
Hence why the compression is necessary to spread out the
That's
tissue.
right. So we want to, breast has a lot of stuff going on in there. It's not just fatty tissue. There's glands, there's ducts, there's Cooper's ligaments. So all that glandular tissue that's in there, which tends to, as we age, be fatty replaced. But as we're younger, it's more dense, more glandular.
Okay.
So all these structures that are in the breast oftentimes stack up on one another, and then it shows up like this little white patch, which is dense tissue, and that could be something else hiding in there. So we have to have a focused look, spread the tissue out, and see it better. So usually patients that have something that shows up, they'll come for that. Sometimes they're also booked for an ultrasound. If we can't make it go away, that's what we say on mammogram. So sometimes we do those spot compression views or just even a repeat view, and it totally goes away. So we know it was just a summation. We call it a summation of breast tissue. So it's just overlapping breast tissue. Now we've really focused the compression on that one area. It's spread away. We can see that there's nothing hiding under there. Patient's good to go. Some patients, obviously, if it persists, there could be a small mass. It doesn't mean that it's breast cancer. It could be a fibroadenoma. It could be a cyst. It could be something benign. It could just be glandular tissue that is dense. But the patient would go for an ultrasound, and then the ultrasound will determine what the tissue is made of. So is it solid? Is it a solid mass, which could be a fibroadenoma or a cancer? Or is it or a papilloma? Or is it a cyst, which is fluid filled? Okay. Or is it just that glandular tissue? So those are sort of some examples, probably not all the examples of what. And then from there, it's determined where the patient either needs to proceed to biopsy. So they'd be booked for likely an ultrasound guided biopsy. Most things are done under ultrasound for biopsies, because if it's a mass that we can see under ultrasound, we biopsy it under ultrasound. Excuse me. The only time we do biopsies under mammograms are usually for little calcifications of the breast that don't show up on ultrasound. So, and those are things that are found really early, like early. And that's when we talk about breast screening, catch this early detection. We're looking for the early stages of breast cancer. So it's before you would ever be able to feel it develop into a lump. So it's little tiny calcifications, or usually end up being what's called DCIS. Ductal carcinoma in situ. So that's like the very first stages of breast cancer. And they show up like little grains of sand that show up in the image, and you can't feel it. You can't even see it under ultrasound. So that's when we do those biopsies under a stereotactic biopsy using the mammogram machine.
Okay, so really
that was a lot.
But informative, very informative. And I'm learning a lot.
I don't even know if I answered the original question, but
can't remember what it was, but as long as I'm feeling better about a potential or my future mammogram, obviously we'll be booking with you, Sarah. And that's exactly what happened in my situation, is that I had been called back for the ultrasound. And fortunately, in my case, they realized it was a cyst. And that sucker stuck around for a long time. And then eventually it just dissipated. It disappeared.
And cysts are they're often cyclical. So they'll come with women's cycle. They'll flare up. That's why you get tender breasts right before your period. They're usually hormone related. So they can come up, and we're not usually too concerned about painful lumps. It's more about non-painful lumps
Okay.
that are hard and fixed. They don't move, they don't fluctuate, they don't go away, they don't move around. They're hard, they're fixed, and they don't hurt.
Like that little bead that we used
Yeah.
to feel in the beanbag when we were kids in
Mhm.
health class. Interesting thing that you mentioned also about family history. And now we're going to switch gears here.
Yeah, sure.
And shift to the other side of Sarah. But there's a bridge, there's a beautiful bridge
Yeah.
between those two sides of you. And that is family history. Now, you had lost your mother and your sister to lymphoma. And so now you're very much aware of health history in your life. Before we go into that, how did you, Sarah, find your way through it and continue to show up at your job, a very important job too for other women? Tell us a little bit about that.
Yes. Well, it definitely has been a journey. I lost my sister, she was age 33, I was 27, to non-Hodgkin's lymphoma. That was back in 2002. And so that was right after I moved back to the Valley here. It was definitely hard navigating everything. And then 2019, lost my mom to the same two types of non-Hodgkin's lymphoma. And she battled for a very long time. My sister, it was more aggressive. She was younger. They didn't have one of the chemo treatments, the CHOP R. They had CHOP, but not the R, the rituximab, I think it's called, at the time. So she was diagnosed in 2000 and passed away in 2002. My mom had a much longer battle. I think she was battling for 8 years. It's definitely was life-changing. And as far as lymphoma goes, there is no, I don't believe there's any direct correlation on family history.
Okay.
Originally, when my mom was diagnosed, I did contact my doctor, like advocated for me to contact sort of the cancer research, and I did this whole screening thing, but I actually never did hear back about that. But I don't know if they've proven. I don't know if they've ever proven any link to that. Yeah. As far as, did you want me to talk about family history for breast cancer as well, or just move more into my story?
You take it in the way that you feel fit.
All right.
I'm getting a little
there definitely are. Yeah. I'll just quickly touch on the breast imaging or the breast cancer family history thing, because does play a role in risk. It's not actually the number one risk for developing breast cancer. The top risks for developing breast cancer are being a woman and being 50 or over. And then there's the previous breast cancer history in very close family relatives. Okay. A lot of, my grandma or my aunt or whatever. We don't actually record those statistics unless there's like multiple family members, and usually diagnosed under age 50 is where we're mostly concerned.
Okay.
And then also breast density plays a bit of a role in that, which we can touch on a bit later too. But yeah, as far as my journey going through the losses I've had and that has definitely opened me up to realizing life is short and working. I do remember after my sister passed away, obviously I had a bit of time off, and then I tried to come back to work. Because at the time, I think I might not have had an actual permanent position yet, because I was still pretty new. I think I was casual. So I wasn't getting paid any sick days or anything like that back then. So I was struggling to come back fairly quickly so that I could pay my rent. And I remember just walking into the hospital and had to walk right back out, because that fear, like the feeling of just been in the hospital with her and everything. And then I just walked in and I was like, I can't do this yet. And I just had to turn around and walk right back out. But, and it was hard with my mom too, because she was local. And because at the time when my sister passed away, well, I shouldn't say that. I was living in Vancouver and I moved back here because of her, actually, because she was sick. But yeah, anyways, and then with my mom, I can let you know, and I'm proud of her because she chose MAID. And so that happened in our hospital. And so I was there for her through all that. And yeah, so it was definitely hard to go back and face that and be in that environment of so many times where I have patients like tell me how they're there for their mammogram. They don't have cancer or didn't have breast cancer, but they've just lost their daughter or their husband or their sister to different types of cancer. And a lot of times it is lymphoma. And so we just have that little moment together. And that certainly happens a lot. It did shift me into my other passion, which is the yoga and wellness. Yeah, shortly after my mom passed away, before that I was really getting into yoga, and then after she passed away, I was just thinking, like, felt like that soul searching feeling, like where I just needed something to fill my cup. And it literally was like the day after her birthday was September 28th, which was her first birthday that she wasn't here for. And then the next day I woke up and there was like an advertisement on social media about a teacher training here in town. And so it was just like, I was like, oh, it's meant to be. And so I just inquired about it. Hadn't even been to the studio, just signed up. And then at the time, I really didn't think that I was going to be teaching either, which I know a lot of yoga teachers say when they sign up for their first yoga teacher training. Yeah. But yeah, I just wanted to do it to deepen my own practice. And then as I proceeded with that, of course, it ended up being during COVID. So I started that in January 2020. And then by March, we were shut down. And so had to pivot and do things online. And then we had to do things outside. But anyways, we managed to get it all done. And throughout that, I was starting to teach a little bit to some of my friends and coworkers online. And so I had my own little bedroom and I'd set up my camera. Nice. I had this little group and started teaching them. And then I started teaching them outside. And then as things went, they're just like, you should just start teaching. And then it just, it totally led into this, well, we had to get the perimeter drain done on our house and let's just redo this other part of the house. And so then, it just went from there. And then did another 500 hours and
good for you.
So
same studio? No, that's when you went.
No, that was through Hallie in Costa Rica. Yes. Yeah. So it's it's great, and it is a great balance because I love my work with women at the hospital. I feel like it's really important and is valuable, and it's just even though we're not always appreciated because there's people, oh, you're just inflicting pain, but it's like for a good purpose, right? So so there's that, and then but also rewarding and a totally shift of like making people feel really good in a yoga class. And but both jobs I'm telling patients people how to move their bodies and positioning them, sometimes hands-on, giving lots of instructions. So that's very similar.
Yes, of course.
I think that part just came naturally to me, which is why I progressed into actually being a teacher and opening the studio, because I'm just used to basically telling people what to do all the time. So that part was pretty seamless.
Oh, goodness.
Yeah. And it's a nice balance of things in healthcare, of course, can be very stressful during COVID. All of that is especially, it can certainly be challenging. And so this is just a nice balance of just a little inner calm. And I think it's just so important. I know you had asked before about that crossover of like health and fitness into like breast health as well, going back to risk factors.
Of course.
Obviously, for everything, our health is so important. So really, diet and exercise, limiting alcohol, not smoking, all those things that play a risk factor in breast cancer as well. BMI, that's why unfortunately sometimes we still collect patients' weight and height for BMI, which is not super reliable, but it paints a bit of a picture usually of patients where they're at and whether they're at higher risk for developing breast cancer based on a higher BMI.
Of course, because as we know, we move into the menopause transition, and I've spoken about this a lot myself on my solo podcasts as well as many guests. We increase inflammation, cortisol levels, stress levels, and these inflammation markers increase, which is a precursor for many diseases, including type 2 diabetes and some cancers as well. So yes, our nutrition, movement, and even the mindfulness and restorative practices such as the yoga that allow us to really get into our bodies and And so you're really taking care of women's breasts in many different ways, Sarah, and we commend you for that. But now you're moving into the menopause transition, and I bet you were having a different, let's say, perspective or empathy for some of the women that are coming in.
Yes, certainly. Funny enough, because when I first started doing mammograms, I guess I probably would have been about 24-ish. And you get the women that are like, have you had this done before? Because they're looking at you and you're young and no, I haven't, but it's not because I don't want to. It's just because I'm not eligible yet. Oh my gosh, I could not wait until I turned 40. I swear I got my first mammogram on my 40th. Just so I could say, I've had a mammogram.
I'm part of the club.
And I wanted to see what my breasts look like. Like, how dense were they? I have no idea. Speaking of density, so that's not anything that you can feel or look at. It's all density, all is about how your breast appears on a mammogram. So sometimes patients say, oh, my breasts are really dense, but actually we take the picture and they're completely fatty. Right. And then in the last couple of years, I just turned 50 this year. So I definitely am feeling the full perimenopausal effects. That's for sure. We get women that come in and they're, of course, we have them undressed. We offer a gown if they want. A lot of women don't bother with a gown because they're just we're going to be touching everything anyway. So they come on over. It takes 5 minutes. They're in, they're out. At the beginning, they're, it's cold, right? And by the end, they're just having a hot flash and they're sweating everywhere. So I totally know about that. And the biggest one that I've dealt with in my little perimenopause journey is the brain fog. It's been quite a thing. So I'm usually very type A, very organized. Don't really make too many mistakes, really on the ball. I'm a supervisor. Certainly have been noticing a few little slips here and there, and it's come. There was a few instances. This is going back probably over a year ago for sure, before I started any HRT, which I have started now. But I was talking to my patients, and a lot of it's pretty repetitive, right? We're always asking the same questions, and so I had a lady come in, and I asked her birth date, and it happened to be that day. A lot of people come in on their birthday for their mammogram. So I was like, oh, it's your birthday. Happy birthday, whatever. And so she comes over and I start to ask her my spiel, my usual questions. And my first question is, any new concerns or issues with your breasts? And instead I said, is there any new concerns or changes to your birth date?
Yes. It's 50 years too far into the future.
Just looked at me and we both just broke out laughing. And then I think it was the same day, I swear, I had another lady, same thing, came over, asked her birthday. She comes over, I'm asking her the questions. I said, is there any changes or new concerns to your breath? That's because we're always telling patients to hold their breath when we take the pictures. So yeah, just like silly things like that. And that crosses over into the yoga thing too, because I've been instructing yoga. And when I first got into yoga, and I sometimes go to yoga classes, I always used to get annoyed by the teachers that would get their right and lefts mixed up, or do something on one side, but then not do the exact same thing on the other side. Or what is this woman doing? She's totally out of it. Well, likely she was perimenopausal, because there's been times where things have come out of my mouth and I'm like, why did I just say that? I don't even know why that came out of my mouth.
Oh, goodness.
So definitely feeling that for sure.
And these are all real and relatable stories. And I think that the more that we can approach something from a position of empathy, relatability. Relatability. Yeah. It makes the experience less daunting. Yeah. But it also helps women realize, you know what, we really are in this together. And it is being in this together as a community that we're going to help each other get through it. The fun times, the hard times, mammograms, and unfortunately losing our loved ones to screwing up your left and right and your down dog from your up dog from your cobra too. But I can relate to that too. And brain fog. That's a real thing. I've spoken about that, and you mentioned it too. Having a career and knowing that you have to show up and perform. I think that you're probably in one of those environments where it is very understandable because of the nature of your work that you're doing. A lot of women struggle with this terribly, to show up their very best.
Yes.
Those little
ears. Show up here, Mary, because I was worried that I wouldn't be able to form words together in a sentence.
It's doing quite well.
I wanted to talk just a few minutes, if I can interject.
Absolutely.
I had talked about who is eligible for screening mammograms. I wanted to touch a little bit on the diagnostic mammograms as well, because there's a little misconception on some women that might not get mammograms because they don't think they need to. And those women often are women with breast implants or women that have small breasts or whatever. Women with breast implants still get mammograms. It's still the regular recommendations every 2 years if you don't have family history.
Okay.
The only difference is that they have to get referred by their doctor. They have to get a requisition sent in just for implant screening or mammogram with, because of implants.
Okay.
The screening program just doesn't allow for those extra pictures. We take 8 pictures with implants instead of 4. So we do 4 where we put the whole breast in, but we just don't really use any compression at all. So we're never going to pop an implant. Okay. And then we do another set of 4 where we push back the implant and then we get some compression on the tissue that's in front of the implant. So they're breast tissue. And so we take 8 pictures instead of 4. So yeah, that is one common misconception, that we're going to pop implants or that we don't do them at all. And we do them all the time. So you just have to have a doctor's referral for those. And then women that, have a new lump, new concern, nipple discharge. As far as nipple discharge, we're not really worried about anything milky or yellow or even brown, green. Those colors we're not too worried about.
Okay.
It's more so if it's bloody or clear. Those are the 2 more concerning colors of discharge. And it's more if it's spontaneous and just out of one side. So if it just happens on its own and you're not squeezing it out per se, then that's a bit more concerning. You should definitely go see your doctor. And with those ones, we do a mammogram and an ultrasound. Women that have other types of discharge will still do a mammogram, but usually we don't have to do an ultrasound for those unless we see something on the mammogram.
And would that be more related to an infection?
It could be, or it could be a little papilloma. So the papilloma's inside the duct, inside the nipple there. Those are often, and they can be cancerous papilloma. So that's why they have to get checked.
Yeah. Okay.
Yeah. So that is for that. And then women that have had breast cancer, they are usually followed by a doctor and followed by, even depending on when their breast cancer was, maybe still the cancer clinic or a surgeon. Those patients are yearly for their mammograms. And they do need to come through the diagnostic. They need to get a referral each time. So I always tell patients, because there's been a few that have been lost in the shuffle, because what happens, people come for their regular screening mammograms. And with the screening program, you get your reminder letters, right? So once you're in the screening program, you'll get a reminder letter every 2 years saying it's time for you to book your screening mammogram again. So people do that. Then you find a breast cancer during your screening mammogram. So then the patient has their breast surgery, all that. Now they're not part of the screening program anymore.
Okay.
So now they have to come in through their doctor. Unfortunately, there has been lapses, and maybe I don't know all the extent of the reason why, but all of a sudden 4 years goes by and the patient comes back for a mammogram and says, well, I didn't know that I wasn't going to be getting a reminder notice. So it's really important for women to educate themselves to not rely solely on their primary care provider.
Yeah, of course.
Which I'll get into. Those last 3 questions was like, advocate for yourself and be responsible for your own health, and really be persistent as well. If you have like a concern, use your intuition. But yeah, just being on top of it, not waiting for, if you keep track, like if you think you're supposed to have a mammogram in a year, write it on your calendar. And then if it's not happening, inquire about it. So those are all just important things, because unfortunately things do fall through the cracks. Things get lost, whatever,
of course,
happens. So just keeping a medical record for yourself is important. So yeah, breast cancer, implants, new concerns, lumps. Those patients obviously will come in, they'll get the ultrasound as well. What else was I going to say about that? There was something else.
So just to recap quickly, stay educated.
Yeah.
Be proactive and advocate, which are 3 key areas in almost all women's health. Women's health.
I can't tell you how many times I've had women come in. One personal story that I know was, a woman comes in, she was like 40, 9 maybe, or something like that. And actually, she was probably like 47. And she came in because she thought she felt a lump on one of her breasts. It was her first mammogram. She hadn't had a mammogram before.
Okay.
And so she comes in, I do her mammogram, and I mentioned to her that she could have, because she's like, I've been asking my doctor to have a mammogram since I was 40, but he said no, that you didn't need to have one until you're 50. And I said, well, just so you know, you could have just came in anyways. You don't need a referral if you don't have a concern. So it turns out the lump she was feeling, there was nothing there. She was glandular tissue, but we found a cancer on her other side.
Oh my goodness.
So things like that happen all the time, which is why I always tell women, unfortunately, doctors all have different perspectives on when women should get screened. And I can tell you from my personal experience, get in there when you're 40, start going, and you're going to catch something that you won't feel. And the whole key is the early detection to save lives, right? To get that treatment earlier. Usually if it's caught early, all you need is a little lumpectomy and maybe some radiation. That's it. It hasn't spread to any lymph nodes. You're not needing chemo. You're not needing a mastectomy. It's just such a big difference. That's what I have to say about that.
Sarah, the information that you shared today is so critical. Just breaking the myths and the fears, and then addressing it from a point of view of empowerment for women, education, like we said, proactive advocacy, being empowered with that knowledge to know that you have in your hands the ability to make wise choices early, 40, and you're early in your perimenopause phase as well, to really make some nice changes, some important changes, and detect as well, early detection. I am so pleased that the conversation just came up haphazardly.
I was going to say, that's one other thing I didn't say yet, which I wanted to just quickly say, not going over.
Not at all.
A lot of women want to just have an ultrasound done and not a mammogram. And ultrasound's really big right now because of breast density. That's all everywhere, right? So it's really important to know why ultrasound does not replace mammography. And that is because, number one, in BC, you can only qualify for that breast screening ultrasound if you've had a recent mammogram that shows your density score. So there's A, B, C, D for breast density, A being the least dense, D being the most dense. So women that are in the CD, so denser breast tissue, do have limits the sensitivity of mammography. So we're not able to detect breast cancers as well as we can in someone with A and B density breast, where there's more fatty breast. We can pick out those white spots that show up as cancers easier in the fatty breasts. So a lot of women don't like having mammograms. A lot of them don't like having them, but have never had one. But some of them have and just don't like to come. So there are women that try to get around the system and try to have their just ultrasound only. And unfortunately, it's not possible for the most part, unless you have a targeted, like palpable lump or something like that, then there's ways around things. But as far as the screening goes, I'm talking about no clinical concern. You just want to have your breast look at. So those patients do have to have a regular routine mammogram done within, I think, 2 years to show their density score. And then they could be eligible for the supplementary breast ultrasound screening. And as far as a targeted breast ultrasound, so say even a patient comes in, they have a lump, they want to just have an ultrasound, they don't want to have a mammogram. We really do try to work with the patient to educate them as to why a mammogram is so important. And sometimes we'll ask the booking clerk to just please tell them to come anyways for their mammogram. They could talk to the tech. We can explain why. And then I swear 9 times out of 10, we're doing the mammogram. But it's often that fear and just the lack of knowledge around why we do it. The analogy that I told you that day, which my supervisor back in the day told me, is when you're looking at an ultrasound, picture yourself in a dark room and you're holding a flashlight and you're just shining that flashlight on the ceiling. That's what an ultrasound it is. So you're only going to see the parts of the ceiling that are lit up. Whereas when you do a mammogram, it's like turning the whole lights on. You're going to see the whole ceiling because it's the whole picture, right?
That's a great analogy.
Yeah. So that's why it's important, because you might feel a lump over here. If we only do an ultrasound in that one spot, we're missing the cancer that's on the inside of your breast, right?
Of
Just
course.
really important.
That is such clarity in your description. Thank you for that. Now, for my listeners of here in British Columbia, Sarah, you brought some literature over here.
I did. Basically, this just goes through the categories of who should get screened and when. Age 40 to 74 for average risk, it's every 2 years. They put a cap on the 74, but it actually doesn't end then. They send reminder letters out till age 74, but women over age 74 can still come for mammograms. They just won't get the reminder letter. And we get a lot of questions as to why that is. I think a lot comes down to, well, we're not going to send reminder letters out forever, for one thing.
Of course.
And also, everybody's health obviously is different at that age. And so women that are healthy and want to be proactive and want to keep screening and know that if they were finding something, they would do something about it, then absolutely keep coming. But not everybody is in that situation. There might be other health issues that are more important.
Yeah.
Also, typically, it's my understanding that breast cancers that are found later in life, like in their 70s, 80s, are usually not going to be what necessarily ends that person's life. They might be able to live with it throughout the rest of their life. Whereas breast cancers earlier in life, 40s, 30s, even 50s, are more aggressive. And we really want to get on top of screening and treating those women.
Is an important message right there.
Yeah.
Okay.
And then as far as the high risk, I had mentioned higher than average, or so the women with the first degree relative with breast cancer are known diagnosis of ADH, which is atypical ductal hyperplasia. So some patients that have biopsy that come back with that, and it's just atypical cell. So it's something that they're going to watch. So they're at a higher risk. It's not actually breast cancer yet, but they're going to come yearly just to be sure it's okay. And then other women, also, it's not on here, but it's women that have had chest radiation. So say they've had like lung cancer or some other kind of cancer, and they've had direct radiation to your chest. That's a higher risk, obviously, of developing breast cancer. And women that have had their genetic testing done in their BRCA1, BRCA2, which is also related to ovarian cancer. There's all those links there. So they're yearly. So that's what this form says. And on the back, there's all the clinics in the province with phone numbers. So there's that. And then it talks a little bit about, this is just what we give to patients sometimes when it's their first mammogram, what happens next. So basically after the patient leaves for their screening mammogram, they go home, they'll get their letter in the mail. They get their own report in the mail, actually. And in about 2 to 3 weeks, a copy of that goes digitally to their doctor or care provider. Oh, one other thing I should mention is that women that don't have a family doctor, which happens a lot around here, you can still book yourself for a screening mammogram on your own without a family doctor. So that's not an excuse to not have a screening mammogram. If we need you to come back for additional pictures, like I mentioned, coming back for those additional views, then the office, like our department, calls the patient, has them come back. Usually it's within a week. You're coming back, having those additional images done. And then that now is a diagnostic report that will be sent to your doctor.
Hey.
Yeah, and then once you're in the screening program, you get reminder letters either every year or every 2 years. One thing I'll mention is that if you ever move, make sure you update address with the actual screening program. They're not linked to the hospital. So if you update when you check in at the hospital, it's a different computer system than the screening program. So what happens is people get lost in the shuffle too, because they move, they forward their mail for 6 months, but they don't get the reminder for 2 years. And then next thing you know, 10 years goes by and the patient's like, oh, I swear it was like 3 years ago. It's about 10 years ago.
Now we understand that with the medical system that we're seeing, there's a lot of backup to get in, but mammogram is different. You're not backed up in this huge waiting list.
Actually, we are pretty backed up right now. It's been quite busy. We had a bit of downtime with our machine install, right? Because we were down for about 3 weeks. And even before that, it's been busy. I think that a wait list right now for a screening mammogram is probably about 2.5 months. So if you're yearly, for sure, get ahead of that queue. when the reminder notices go out from the screening program, it's from the head office, and they don't necessarily pay attention to every site's waiting list. So they just send it out. I think it's two months in advance. And so by the time you actually make that phone call, next thing you know, you're all of a sudden 2 months behind of when you should be getting done. Let's put it this way. If you're due in February of next year, you should be phoning right now, because that's what we're booking into right now.
Excellent message. Nice little reminder. Can I tell you my funny mammogram? Okay, this wasn't an actual mammogram. We did a mock mammogram. I had a contract with to celebrate the 100 years of St. Joseph's Hospital in 2013. And I had hired a beautiful videographer, and he created this lovely montage of stories of care with compassion. That was
I was involved with that.
Were you involved with that?
At St. Joe's?
At St. Joe's.
Yes. Oh, yes.
So we brought in.
Yep.
Okay.
Yeah.
Well, they needed a model for the mammogram, and the foundation who was in charge of overseeing these projects for celebration said to me, Mary, why don't you just throw on
capes,
the cape, and we're going to be filming from the backside, and our videographer, Zach, male, a funny guy, great guy.
That.
Exactly. Yes.
I went to BCIT with him. We lived in residence together.
Very small worlds we live in. So they just film it like pretending that I am just placing my breast onto the squishy. Yeah. And then they pan over to the machine, and they'd use somebody else's pictures.
Okay.
But she had massive breasts.
Yeah.
Well, didn't we just lose our shit in there? Because I'm looking down my little belly going, this doesn't add up.
It's not me. Is it on magnification?
It took a couple of takes. But was that ever just an icebreaker for the whole situation?
That's hilarious.
I'm going to put the link to that video if it's still up there on YouTube.
Because actually, I think that I do remember, because 2013 was the year I became the supervisor in there.
Oh,
yeah. And
incredible.
Yeah. So I think I do remember that. I don't think it was me that was actually there on that filming day. But I remember Zach and everybody coming around with video cameras. We did photo shoots and everything.
We did photo shoots. Yeah. We did a scene in Emerge, which ended up being, I thought this take took a long time. It took several takes when they were doing Emerge, because it just turned into a gong show. Everybody was being silly, and that's care with compassion.
Yeah.
Speaking about care with compassion, I segue to our nice closure. Sarah, honestly, your care, your compassion, and lived experience, not only just as there to help women through their fears of a mammogram, but lived experience for understanding the journey of healthcare and what it is to lose someone we love dearly and find a way to heal for yourself. So thank you for sharing and enlightening us with such powerful knowledge on mammograms and why it's so important for screening during 40s and onward. It all comes down to quality of life.
Empowering, and the fact that we can actually do something for ourselves. We can take control of our health in that way.
Beautifully said. Thank you for joining us today.
Thank you so much for having me.
I want to close this conversation with a real moment of humility. Going into this conversation with Sarah, I'll be honest, I carried some fear, some skepticism, and a lot of unanswered questions about mammograms and breast screening. And this interview was, for me, a big dose of humble pie, but in the best way. Being properly educated about the safety standards, the technology, and the care that goes into breast screening here in British Columbia shifted something in me. It didn't quite erase every feeling I had, but it certainly replaced fear with context. And that's what matters. And then, in one of those perfectly timed life moments, Sarah called me shortly after a conversation to say there'd been a cancellation. Do I want to come in for a mammogram? Sure enough, I went in. And yes, like many women, I was called back for more imaging. And all I want to say about that is this: a callback is not automatically bad news. It's information. It's clarity. It's the system doing exactly what it's designed to do. Sometimes the reason for additional tests might include either the diagnostic needs specific x-rays of an area of concern, or an ultrasound is necessary to use sound waves to produce an image in a specific area, or sometimes it's for a biopsy to take a sample of tissue from the area of concern. But this does not necessarily mean cancer was found. According to the research, over 95% of women called for additional tests do not have cancer. Right now, I don't have the results to share with you for my second round. I'm going in this week. But what I do have is a deeper trust in the process and enormous respect for the professionals like Sarah who do this work day in and day out with such precision and care. And I have a renewed commitment to making decisions from a place of informed choice, not fear, which is exactly what this platform is all about, to inspire women to make informed decisions about their healthcare needs. So if this episode stirred something in you, be it fear, resistance, curiosity, or even relief, my hope is that you take the feeling and turn it into conversations with your care provider. You deserve clarity and support, and you also deserve to feel empowered in your healthcare decisions. And if you live here in British Columbia, you can visit the screening website online at screeningbc.ca/breast. Thank you for tuning in here today and for listening with an open heart. If today's insights resonated with you, I'd love for you to be a part of our growing community of menopause disruptors. Hit that subscribe button wherever you're listening right now. And if you know someone who can benefit from these conversations, please share this episode. Sometimes a simple act of sharing can be the first step in someone's healing journey. And hey, if you're ready to take the next step in your menopause journey, I'm here to support you. You can find all my services, including my comprehensive menopause intelligence digital course, one-on-one coaching programs, and workplace education services at mlcoaching.com. It's in the show notes. Want to stay connected and get regular doses of menopause wisdom? Follow me on Instagram at Menopause Disruptor Podcast, where I share tips, insights, and real conversations about navigating this transformative phase of life. Let's continue to disrupt this menopause conversation together. Remember, midlife should be the best life, and it will be. Namaste.